Hi, I'm Dr. Pamela Morris. I'm here on day 2 of the Women's Health Masterclass, and I'm joined today by Dr. Sadia Khan, who is Associate Professor of Medicine and Preventive Medicine at Northwestern University Feinberg School of Medicine. We really had a wonderful session today, really focusing on diabetes and cardiometabolic health across the woman's lifespan. And we started out with your discussion, which was incredibly pertinent, regarding optimizing pre-pregnancy cardiometabolic health. So talk to us a little bit about how you approach women who are in their reproductive years and maybe have cardiometabolic risk factors.
Thanks, Dr. Morris. It's a pleasure to be here. And it was really an exciting discussion because one of the things that we know is that pregnancy can represent a natural stress test. And so oftentimes, even if there are risk factors coming into pregnancy, people may not yet have a diagnosis of diabetes or hypertension, but the stress of pregnancy can really unmask that risk, particularly with a diagnosis of gestational diabetes, hypertensive disorders of pregnancy, even other complications like preterm birth. These can all be red flags or markers of risk during pregnancy. But what we know is that there are known risk factors for these conditions that we can target before someone becomes pregnant. A lot of times people may not know that they're going to become pregnant or may not be intending pregnancy. It can be unintended in half the time. But that if we take an approach throughout the reproductive years of optimizing cardiometabolic health, whether someone is intending pregnancy, is pregnant, or even in the postpartum period, because sometimes that can be pre-pregnancy for the next pregnancy.
And in terms of who should be approaching these women, you and I talked a little earlier about we're both preventive cardiologists, and a lot of these women are not in our clinics. Unless they perhaps have been referred for management of hypertension or management of a dyslipidemia. How do you approach, or who should be following these patients and who should be giving them counseling? How do we coordinate that?
Yeah, it's a great question, and it's definitely one that comes up a lot during that pregnancy to postpartum transition as well, or thinking really broadly across the reproductive years. We know that family medicine, internal medicine, and obstetricians all provide primary care. So I think one of the first and most important aspects is making sure that someone has a continuity clinician that they are able to connect with and receive care. Sometimes that's a healthcare access issue. Sometimes it's a priority issue where realizing and recognizing how important that time is. Like you mentioned, preventive cardiology is a great place for a specialty consultation in someone who may have risk factors developed during pregnancy, like preeclampsia, for follow-up after a pregnancy that's complicated by hypertension. But we really want to ensure that there is ongoing continuity of care for screening for these cardiometabolic conditions. A lot of times people who have gestational diabetes are not really rescreened, even though we know that there should be an oral glucose tolerance test done in the postpartum period, an annual A1C screening following, given the high risk of developing diabetes. It's nearly 50% in the next 10 years after a pregnancy complicated by gestational diabetes.
We know that it certainly is true now that recognition of the importance of not pre-pregnancy, pregnancy, and postpartum, it's really been emphasized how critically important this time period is for women at high cardiometabolic risk. And we have now cardio OB clinics popping up everywhere. One thing that I was most struck by during your presentation was the discussion about how we need a systemic structural approach. And I was wondering if you could talk about all of the factors that can impact a woman's risk for complications during pregnancy and how we can target some of those factors.
I think we really are having a growing awareness of the fact that there are individual level factors that can influence a woman's risk during pregnancy, but also interpersonal, psychosocial stressors. We heard about that yesterday. The community level factors, where you live, your zip code is more important than your DNA code, is a common theme that we've heard in other health conditions and just as important during pregnancy. And then thinking about those structural and policy level changes that are needed. I think a great example is Medicaid extension, where we're seeing many states now adopting this policy for providing access to care in the 1 year postpartum, recognizing what a critical period that is for optimizing health and preventing maternal mortality.
I think one of the most valuable things that we find is you cannot manage a problem or cure a problem unless you are made aware that you have the problem. And I think right now, loud voices like yours that are highlighting the importance of the pre-pregnancy period is critically important. Well, thank you so much, Dr. Khan, for joining us here today. And this is the kind of important information that is covered at the conferences of the Cardiometabolic Health Congress. And we're all so glad you could join us today.
Thank you.